Thank you guys for coming out, and thank you to those on the live stream. My name is Joe Graffy. I'm a Director of Enterprise Partnerships at Arcadia, and today I'm going to be talking about managing your employee population. We're going to go over a couple things, but primarily I want to get to the barriers to managing your employees. There are a number of factors that you need to manage when you are managing your employee health population. Primarily, the fact that you need to give equitable benefits to everyone of your employees and give them the opportunity to decrease their premiums at the same rate. Now, you can imagine that that's pretty tough when you're talking about different comorbidities, right? Some people have CHF, some people are smokers, others are young, healthy individuals. So how do you equitably incentivize those groups of individuals to reduce their premiums throughout the year? We're going to go through how one of our customers used Arcadia to stratify their populations, the workflow and cost savings that they saw, and then the continuous improvement initiatives that they work on every year to make sure that they are staying up to date. Just to give you a quick overview of the population, we're talking about a large health system with about 100,000 employees across the country, targeted in the Midwest primarily, using a third-party TPA to pay their claims and extend their network nationally. And so what I mean by that is, as you can imagine, as a healthcare provider, you want your employees to come to your healthcare system. It's cheapest for you, right? But what if you are extending your employees remote employment in Nevada, Utah, Alaska? How do you make sure that they get the care that they need? And so they were leveraging that third-party TPA to borrow their network, for lack of a better term. And so what you get through that is you have a preferred network, a tight circle around your employee population, and then you have a larger network that extends beyond that, that's slightly more expensive, but still preferred for your population. The goal, as we talked about off the top, is to equitably incentivize all of your beneficiaries to engage in healthier behaviors throughout the year. So what this customer did is they broke their population into two general buckets, and then one of those they further subdivided. So we have folks who fell into a disease state, right? So folks with obesity, asthma, diabetes, hyperlipidemia, hypertension, and smoking. Those subgroups had to be further divided into high and low risk individuals, right? For some smokers, you're an everyday smoker with a lot of comorbidities, high risk of cancer. But the real question that you need to ask across that population is, will care management actually improve the outcomes for this patient? For non-disease states, you still need to offer an equitable way for employees to reduce their premiums throughout the year. So if you're going to offer care management to your disease states throughout the year to reduce their premiums between 15 and 30%, then you need to also include an incentive for non-disease states to reduce their premiums by that same number. And so what this customer did is they said, okay, if you do not fall into a disease state and you wear a step counter throughout the year, we will give you a 15% reduction on your premiums next year. If you meet your goal of 180,000 steps throughout the year, you get a 30% reduction on your goal. And that can also be applied to your dependents on your plan as well. For the disease states, what they did was enroll folks in care management, those in a low-risk care management plan. If they just signed up for care management, would get 15% off their premiums. If they met their care management goals, would hit a 30% premium that was equitable to the step count incentivization. Now, how this process worked is throughout the year, we have our kickoff in December, and then we have an appeals and enrollment process that takes place throughout the months of January to March. Let me just get you a quick example of one scenario that might call for an appeal. So let's say you're reaching out to folks for obesity. You're looking for anyone in the chart who gained over 20 pounds, 15 pounds in the last 6 to 8 months. We have 7 individuals, women between the ages of 30 and 40, come up and say, actually, I'm pregnant, right? So how do you make sure that you are using the data that you have to remove those false flags and not reach out to those women who you're flagging and telling them that they are falling into your obesity care management program when they're actually just pregnant, right? That's a really awkward conversation for you to have with your employees if you don't have the data and the synchronicity to understand their full continuum of care. The same can be said for folks with asthma. Some folks who are admitted into the ER will be prescribed an inhaler for their visit to the ER, but that doesn't mean that they have asthma. So it doesn't necessarily mean that you can look to the prescription for an inhaler to pull them into this care management bucket. As you can tell from those 2 examples, that appeals process takes hundreds of hours from care managers. And so the goal for our health system was to reduce false positives by as much as possible, because a single reduction in a false positive saves one care manager between 30 minutes and 5 hours. That's 30 minutes and 5 hours that they can spend doing real work outside of your organization to make sure that that the population that you're managing is healthy. Once those appeals are locked in and folks are locked into their care management programs or step count incentivization throughout the year, we have our assessment period run throughout the year. And so what that looks like is either your care manager will set a goal, or you will have your step counter goal, and that will get measured over the 9 months between January and September, right before open enrollment begins for all employees once again in October. Between November and December, premiums are then determined for the following year. If you enrolled in either the care management goal or the step count incentivization, you will receive 15% off your premiums. If you hit your goals, you'll receive 30% for the next year, and then the process starts all over again. So, what is challenging about this? If you remember back a couple minutes ago, we talked about the buckets of disease states that folks could fall into. How do you create those disease states? For a lot of folks, the answer here is the Johns Hopkins ACG risk algorithm. The catch there is that the risk algorithm, itself says that it shouldn't be used for cohort building in the first place. And so how do you get around that? How can you modify or take the Johns Hopkins ACG algorithm and then modify it to further filter out the false positives that we talked about a few slides ago? Your goal, once again, reducing false positives, having as tight a group of disease states as possible that are as accurate as possible, and reducing those hundreds of hours of overhead for the care managers. Now, as you can imagine, data quality was a huge concern for this customer. They have over 200 feeds coming into Arcadia. Prior to Arcadia, they had 200 EHRs to manage this data across. They had poor interoperability across those EHRs, and they had bad data quality coming in from supplemental data sources like Weight Watchers or other personal devices. The other piece that was made things really difficult is that data wasn't synchronized. And so the data in the EHR was more up to date than the data that they received as an extract out of other EHRs, which was way more up to date than the claims that they were receiving from the payers. And so how do you make sure that all of those data sources are in line? Because what that asynchronicity did is it made it impossible for them to trend individuals. So they had no continuous picture of whether someone was an asthmatic throughout the year or if that person just happened to be an asthmatic right before the enrollment period. And what they also found is that some people were gaming the system. And so what they would do is that person would go to the ER right before open enrollment in September, get a prescription for asthma because they would rather have that care management visit once a week to make sure that they had their inhaler with them than they would rather take those 180,000 steps throughout the year. That was a much easier way for them to get their 15% or 30% discount. Further, without any trending, you would see that patients that didn't have any relationship with any provider would just fall off of tracking entirely. And so what that meant is that you would actually have people that did have hyperlipidemia or did have CHF that just weren't managing their care fall into this bucket of people that weren't being called out for the disease state. And what that resulted in is you have this now very unhealthy, very expensive individual who isn't being caught by the care managers and whose care isn't being managed. And so what we did is we loaded all of their data sources, created full historical longitudinal patient integration, and we built those 6 cohorts within our Foundry SQL database that allowed for our customer to trend that data month over month to give them a full picture of that person throughout the entire year, flagging what that data was that caused them to be enrolled in the program, where that data lived, why it counted for enrollment in the ACG criteria, and how they could resolve it. And what that also did is it creates a simpler map to chase for those care managers so that they can better understand why this person was flagged and whether or not this appeal is valid. Now, we're currently going through the first year of evaluation with that customer. And at the end of the year, we'll be evaluating how we can continue to improve this program going forward. So that will include things like, how do you manage these high-risk individuals better? I think something you hear in the healthcare space, but is worth merit everywhere, is you can't manage what you don't track, right? You can't manage what you can't measure. And so now that we have these cohorts flagged, our question will be, how do these cohorts perform? How much do these cohorts cost to manage? What care pathways are effective for managing the cost for these cohorts? And then once you understand those triggers, how can you make those systems more automated and efficient? That's my last slide. Are there questions from the crowd? Yeah, go for it. Oh, so that's a really tricky one. Our customer just settled on step count because they found that that was a healthy predictor that was reliable that they could look to. I've seen other organizations offer things like, if you prove that you had a gym membership or gym attendance, that certainly is an option. But the tricky part there is like, what did the person go to the gym and do, right? If you go to the gym and sit in the sauna for an hour and a half, is that as much of a predictor of taking your 180,000 steps throughout the year? Which is why they settled on the single healthcare plan for just the step count. Yeah, definitely. So it's really the team of care managers at the customer that takes on the majority of this work. That does include the providers that support those care managers. So there are certain instances where appeals will need a provider to weigh in on why someone is being flagged for a care management program and whether that's actually appropriate. But it's, the patient's care team is the primary group. All right. Thanks, guys.